Thank you for joining us with our webinar today. We will begin right at 10 o'clock. Thank you. Good morning, everyone. I'm Rebecca Vickers, and on behalf of the Florida Alcohol and Drug Abuse Association, welcome to today's webinar. This webinar is being made available through a collaboration of the Florida Department of Children and Families, Office of Substance Abuse and Mental Health, and the Florida Alcohol and Drug Abuse Association. Please note that as an attendee, you are in listen-only mode and will only be able to view your name. If you have questions, please send them to the presenter and me, the host, by using the chat panel. The button to open the panel is usually located in the lower right side of your monitor. Please use the chat panel to send any questions you may have as you think of them. The presenter will address questions as time permits. Our audio is broadcast through the internet to your computer. If you experience poor computer audio, there are a few options to try on screen right now, and these options will be posted in the chat panel for you as well. If you continue to experience poor audio through your computer, try rejoining the webinar using the I will call in telephone option. You must be connected to the audio of this presentation and view it on screen to receive a certificate of attendance. The recording and materials used in today's presentation will be available on FADA's website in 30 business days. To access the recording and PowerPoint, go to www.fada.org, then to our Resource Center, and then to our training library. FADA produces many webinars and workshops through the support of the Florida Department of Children and Families. To help participants track credits earned through attendance, we host an online community that provides a personalized digital journal where participants can maintain statements of credit for webinars and workshops taken through the Florida Alcohol and Drug Abuse Association. At the end of today's webinar, the web browser will direct everyone to an evaluation form on FADA's website. You will first need to register or sign into your account to complete the evaluation. Information you provide FADA as a part of registering remains confidential. Statements of credit will be posted 30 business days after the evaluation closes. Completing the evaluation is necessary to receive CE credits or to access your statement of credit. Please note that the evaluation will close midnight Tuesday, April 19th. Up to 2 continuing education credits are available for participating in today's webinar for persons licensed through the Board of Nursing, the Board of Clinical Social Work, Marriage and Family Therapy, and Mental Health Counseling, and for persons credentialed through the Florida Certification Board. If you are a licensed healthcare practitioner, be sure to include your Florida license numbers for reporting to CE Broker with our site. If you are certified with the Florida Certification Board or licensed outside of the state of Florida, you do not need to provide your certification number when you register with our site. Please note that WebEx monitors arrivals and departures of attendees and provides a report upon completion of the event. We are not permitted to provide a certificate of attendance if you do not attend the entire webinar, and we are not permitted to provide partial CE credit. Gabriela is the Associate Director of the National Center for Domestic Violence, Trauma, and Mental Health, as well as the faculty at University of Chicago, where they direct the Alcohol and Other Drug Counselor training program within the Crown Family School of Social Work, Policy, and Practice. Gabriela brings over 15 years of experience supporting people impacted by structural and interpersonal violence through evidence-based clinical, housing, resource advocacy, and HIV integrated care programs. Currently, Gabriela authors best practice, leads nation's capacity building effort, and provides trauma-informed policy consultation to advance health, equity, and social justice. And now I'd like to welcome our presenter for today, Gabriela.
Thank you so much. Thank you so much for having me today and for this warm welcome. I'm so glad that folks are able to join this morning, and I'm just so honored to be able to share this information with y'all. Culturally responsive and evidence-based care with older adults in behavioral and integrated healthcare settings. So you already heard about me, so we'll keep going. So our learning objectives for today is that as a result of participating in this webinar, y'all will be able to first identify at least 3 risk factors for substance use that uniquely impact older adults. Second, that you'll be able to describe culturally responsive and evidence-based approaches to the clinical screening and assessment of risks related to substance use with older adults. And finally, third, that y'all will become familiar with evidence-based practices in the treatment of substance use concerns with older adults. So first, getting a lay of the land here, becoming familiar with the background, the context, and the unique risks that older adults face. So first, some data on our aging population and on alcohol use. So the most recent census shows that our country's population of people 65 and older grew by over 1/3 over the past decade. This is an increase that wasn't matched in any other age group. So really a quickly growing part of our population. And then specifically in Florida, 1 in 5 people are over the age of 65. and that risks related to alcohol and other substance use among older adults are also increasing, with 65% of adults 65 and older reporting alcohol use that is beyond the daily guidelines, and that this happens, according to the reports, that that this exceeding of the daily guideline happens on at least a weekly basis. So really common. So now I want to invite all of you to enter in the chat. What are some risks related to alcohol and other substance use that can uniquely impact older adults? You may need to click on a button that looks like a little speech bubble, and it may say chat. You may need to click on that in order to open up your chat. And then you may need to select to send it to specifically me or all the panelists so that we can be sure to see it. And then as they come in, I'll read them out loud because I'm also aware that folks can't necessarily see what other people are putting in the chat. So here we have health concerns, stroke, right? So increased risk of different health concerns, including stroke, heart attack, seizures, and increased risk for fatality. Yes. There can be increased risk on memory loss, and potentially just overall cognitive, cognitive functioning. Absolutely. There's a higher risk for interaction with medications. Yes. There are a lot of medications that interact with alcohol and other substances. And as we age, we're more likely to be prescribed medication. So absolutely, that interaction with medications. The social isolation. Yes, that this can be a time of life where for many different life events, there can be some barriers or interference with our social links, with our social network, and there can be increasing experiences of social isolation, and how that can also be a risk factor for alcohol and other substance use. And then if somebody were having some adverse effects related to alcohol or substance use, then not having that social network to rely on. Right? We are social creatures, absolutely. The loneliness, going along with that social isolation, the loneliness being our subjective experience of that social isolation. And then here, I see grief, right? And that these three can be so incredibly intertwined, the social isolation, the loneliness, and the grief from different kinds of loss and bereavement, both the loss of friends and family members, potentially one's partner, and then also the loss of potentially our role and or health or mobility, right? So grief from loss of loved ones, but also some of that what's sometimes called ambiguous loss, or kind of other kinds of quality of life loss. And then here we see a couple people wrote falling, right? The risk of falls or falling, especially if alone. Yes, absolutely. We know that there's a lot of different complications that can come into somebody's life, especially health complications, and then other complications where a fall can be extremely dangerous and can have somewhat of a domino effect in our ability to remain independent and our overall well-being and then quality of life. Here we have someone mentioning health, right? There can be unique risks to health, and then finances. Absolutely. The financial burdens that can come along with alcohol and other substance use. And then knowing that many times in this stage of life, many of our elders may not be working, may not be able to work, and may not have stability in those sources of ongoing income, especially when faced with increasing costs. Those increasing costs can come from medical care, they can come from housing related costs and increases in things like property taxes, inflation, right? All kinds of different increasing costs that people may be facing in this stage of life, while at the same time, income is not increasing, right? And so, how far a dollar can stretch is kind of is shrinking. Side effects of medications can be potentiated by alcohol and other substance use, absolutely. And then here, oh, I see a lot more people wrote around isolation, social isolation, as well as depression, right? There can be increasing risks around depression, anxiety, and the person's environment and those environmental stressors and the lack of social support can certainly play a really large role in that, as well as the substance use itself may have that effect, right? May also, worsen things like depression or anxiety, or maybe used as a means of attempts at coping with things like depression and anxiety. Here we see that people have said, there may be delays in healing from illness and injuries. Yes, we may not be able to bounce back as easily as we did in earlier phases of life. And then, of course, alcohol and substance use can also complicate some of the healing from illness and injuries. Increased risk, potentially, of suicidality, um, going along with that depression, that grief, that hardship. And then also here, increased risk of intimate partner violence, and as well as potentially elder abuse, being abused, particularly by those that we may rely on in this phase in life. Challenges in nutrition. And then finally here, somebody has entered in the chat that they're finding that a lot of the older adults that they're supporting are having some of that beginning onset of dementia, potentially some of that early mild cognitive impairment. And then along with that, there seems to be a pattern of then alcohol or substance use either beginning or increasing as a form of coping with those changes. So having a lot of kind of difficulty with those changes, and then having some attempts at coping with alcohol and other substance use, and that in turn is then creating a higher risk for things like self-neglect or struggling with self-care, and then potentially even exploitation from others. Thanks so much, everyone, for sharing all of this. And we will be unpacking each of these and taking a deeper dive. So in some of the unique risks and barriers, here are just some very, very broad categories that most of these were already mentioned in this previous slide. So those life changes, right? And some of those life changes also include health changes. But before I go into health changes, something I'll say about life changes is, there may be changes in what the person is engaged in day to day. For people who may have been working every day and maybe have stopped working, especially if that wasn't by their own choice. Maybe it was they were forced to retire, or they had health changes or life changes that forced them to retire at that point. That transition in and of itself, going from that stable source of engagement, activity, for many people, potentially social engagement, being around others, right? So much of the time that we spend in the relationships we form many times are in when we're engaged in work. That stability of routine, right? And having that change. That alcohol and other substance use may be something that becomes somewhat of a time filler if the person isn't sure or isn't engaged in other life pursuits and in other means of socialization and connectedness. And really, what we're talking about for many folks here is also a sense of purpose, a sense of meaning, a sense of connectedness. Also, life changes can be things that people raised, like grief and loss, changes in social support and social networks. Um, and then also here could also be changes in even where we live, housing changes. That can be an incredibly difficult situation for people. The World Health Organization has actually named moving as one of the top life stressors, right? And especially if that move is not something that the person has chosen for themselves, if it represents a sense of loss, um, if it represents, a loss of autonomy, right? And independence, all of these, a change in residence isn't just a change in address for many people. Then along with those life changes, also health changes, many of which have already been named and that y'all went ahead and put in the chat earlier. So a couple of specific things I'll name here is that as we age, we're more likely to experience mood disorders like depression. We're also more likely to experience lung and heart problems, as well as memory issues, which people have mentioned. And that the use of alcohol and other substances can worsen these conditions and can really exacerbate the negative, and that these conditions in turn can exacerbate the negative health consequences associated with alcohol and other substance use. Part of that risk has to do in changes in how we metabolize, changes in our metabolism. So older adults, or I should say just any of us as we age, we typically metabolize substances more slowly, which then means that we can also become much more sensitive to the effects of alcohol and other drugs. And that some of the effects of alcohol and other substances, things like impairments in judgment, diminishing physical coordination or a reaction time that is slowed down, some of these effects that they can then increase the risk of accidents, such as falls, like people mentioned, as well as then also um, uh, car accidents. And then the falls, the car accidents, and other kinds of injuries then can pose an even greater health risk. And as was mentioned earlier, a longer recovery time from these accidents and injuries, as well as many times a domino effects to other areas of our life. And then, the prescribed medications that, so here I'll share some data, and this comes from a report from the National Institute on Drug Abuse that they published in 2020. So there was a study of 3,000 adults aged 57 to 85 that showed that it was really common for adults to be prescribed not only one medication, but many medications, and that it was very common for there to be mixing of prescribed medications, non-prescribed medications or substances, and then also dietary supplements. And that when there's any of that mixing, that of course can increase some of the risk. Um, and that this same study found that 80% of the study participants used at least one prescribed medication daily, with almost half, almost 50% using more than 5 prescribed medications or supplements. So that put at least 1 in 25 people in this age group at risk for major drug-drug interactions, as well as the accidental use of a prescribed medication not as prescribed, right? Not according to how it's prescribed. So that in and of itself presents a whole different kind of risk profile, and that many times people may be doing their best to take medications as prescribed. Medications can certainly be very confusing and then can be difficult. Medication adherence can certainly pose a lot of different challenges at any age. And then to have kind of more to manage in terms of medication can then increase that risk. So here at the top, we see friends and family and then service providers. So here, we already talked about some of the potential changes in social connectedness. So some things that I'll add here around friends and family is that friends and family may either overlook alcohol or other substance use that may be posing some risk. They may overlook it for many different reasons. Sometimes there are some attitudes that are really not helpful. They're really actually very kind of they're forms of ageism, but there's some ageist beliefs or attitudes that if they talked with an older adult about their alcohol use or other substance use, and an older adult wouldn't be open to that conversation, that the older adult would be not only closed off, but potentially upset by the conversation, or sometimes the ageist beliefs that older adults wouldn't be interested in any kind of support or service around their alcohol or other substance use, or that if they were to access a service, that it wouldn't be helpful because of their age. And so sometimes there are other kind of beliefs that get in the way, that beliefs such as, well, they've worked their whole life, and so if they're drinking more than they should, then let them, right? This is the stage in life where they get to. And that these beliefs can be certainly very harmful. For all the different risk factors that we just discussed, as well as the fact that, what's been found time and time again is that when we approach older adults with the respect that everyone deserves and in ways that are culturally responsive, that they're absolutely responsive to these conversations and responsive to care. So we'll get more into what that looks like later in the presentation. These same barriers can also come up with service providers. Service providers also feeling a hesitance to talk about alcohol or other substance use for many of those same reasons. Or also feeling like, well, it's not their place to ask about alcohol use or other substance use. And that's why it's especially important for older adults who are more likely to be engaged in some kind of care, whether it's primary care, specialty care, but that these conversations get integrated across healthcare settings, that it's not something that is just for substance use counselors to talk about with folks. And I invite folks to, keep putting stuff in the chat. If there are different thoughts that are coming up or questions that are coming up as we're going through this, please, please, please put it in the chat. I'm more than happy to have this be a conversation. So here are some risk factors concerning, so these are concerns related to substance use in older adults. So these are risk factors that can increase the likelihood of experiencing some concerns related to alcohol and other substance use. So retirement, especially when it's not voluntary. The loss of primary relationships, particularly loss of spouse or partner or other close family members. The environment, particularly relocation to places where they may have less independence. When there have been changes in physical health, especially pain, high blood pressure, sleep and mobility issues. A history of trauma. So a history of previous traumatic events absolutely is a risk factor for experiencing some risks related to alcohol or other substance use later in life. Mental health diagnoses, and here especially common mental health diagnoses of depression and anxiety, as well as cognitive decline. Some of the most kind of best known are things like Alzheimer's. At the same time, really just mild cognitive impairment can certainly increase risk for developing concerns related to alcohol and other substance use. Those social changes, becoming less active and socially disconnected from family and friends, the economic stressors. So here, the rising medication and healthcare costs, living on reduced income. And then here, of course, this is a risk factor regardless of age. We know that either a lifetime history of a diagnosable substance use disorder or a family history of a diagnosable substance use disorder, we know that that is often a very common risk factor for developing concerns related to alcohol or other substance use. Living in an area or being in an environment where there's a high availability of substances. So it's very easy to access substances. And there may also be some community norms potentially around substance use in ways that may pose some risks. And then, of course, that social isolation. So we want to be aware of these risk factors, and we want to actively be working together to mitigate some of these risk factors, to decrease them, and then actively support protective factors. I'm going to pause here. In the chat, I'm not seeing, someone writes, I'm not seeing the entire chat from other participants. Thanks so much for your question. In this platform, the way it's set up, folks won't be able to see what other participants enter, but what I'll do is that as I see folks enter in the chat, I'll read it out loud so everyone can benefit from it. So we want to create programming. We want to connect with resources that both assesses for these risk factors and then actively supports to prevent and mitigate these risk factors. My guess is that most of the things on this list are not surprising for folks, that we know that this is a lot of the common experiences of older adults in our communities, and that we can actively be working together to prevent a lot of these situations and then also be aware when these situations come up and mitigate them. So then also protective factors. And in that same vein, building programming that really enhances and builds on these protective factors. And these protective factors specifically are factors that can reduce um, the reduce the the risky use or of alcohol or other substances, or prevent it altogether, and that they are in addition to a person's individual, family, and community strengths, skills, and abilities, as well as protective environmental factors. So some of these that we want to highlight here are, of course, resilience. Understanding that we all have innate resilience and an incredible capacity for adaptation to circumstances that can be difficult. At the same time, we certainly don't want to over rely on resilience. We don't want to, accept aversive situations. We want to work to change those harmful situations and environments while also recognizing people's innate capacity to adapt and thrive even when faced with harmful situations. Some other protective factors here are, um, satisfying and happy marriages or committed relationships, supportive family relationships. So we'll talk a little later about the importance of engaging family and providing that family-based service and support. Of course, if the person wants that, and if and then including whoever they define as their family. That retirement, when it is chosen, can be a protective factor. And there again, we're looking at all of the symbolism around retirement, right? Is it something that represents a loss and was forced and is taking away my choice? Or is it something that I'm able to choose myself and I see as something that, even though it may be bittersweet, still is something that I look forward to, right? So all of the symbolism in that and how different it is, whether or not it's voluntary. The ability to live independently, so always highlighting the importance of, when possible and when it's what the person prefers, being able to age in place and being able to have the services follow the person so that the services can attend to the person in the environment of their choosing. Access to basic resources, right? And this is important regardless of age, that when we don't have access to basic resources such as safe housing, food, ability to cover our bills, ability to afford the cost of healthcare, right? All of these different pieces that those are core parts of recovery capital. And that the lack of them certainly cause a lot of problems when it comes to having substance use and alcohol use related health. A positive self-image. And here being important, taking into account, right, ageism and how ageism is very prevalent and absolutely is an attack on and can have an impact on people's perception of self, right? So that positive self-image. Well-managed medical care and using medications as prescribed. And again here, understanding that many times people are doing the best to manage their medical care and medications and that some support. There's a lot of things that we can help folks with to really simplify some of those different regimens so that adherence is much higher, much more accessible, and then people can also have the benefits of that medical care, more effective medical care. The sense of identity and purpose. Again, so important across the lifespan. And just noticing that in this stage of life, that there is, there is a point of transition for many people, and things that may have informed their sense of identity and purpose may be in flux. And so, we want to absolutely support people in that meaning making, in that self redefinition, if and when that is important for somebody. And we want to actively counteract any kind of, you know, kind of pulls towards ageism to try to prescribe what a person's identity or purpose should be in this phase of life, right? And then, of course, supportive networks and social bonds. And sometimes this may also mean making brand new relationships, which people may not have had to do in a while, right? People may not have had to establish new relationships for a while. And so, whenever possible in our programming, creating programming that is also fostering peer connectedness and social support within the program, and then also in the community at large. So we talked earlier about some guidelines for alcohol use and drinking beyond these guidelines. Now, part of it is that the guidelines for moderate alcohol use, they change in older adulthood. And so it's very common for older adults to be drinking beyond these guidelines at least one day a week, for many weeks. And part of the reason is just a lack of information around what are the guidelines and why are these the guidelines. So our guidelines that are established are specifically for women and men. There are not published guidelines that are specific for gender nonconforming or non-binary people. It's certainly an area of growth. So the guidelines that are established are 1 serving of alcohol a day for women and 2 servings of alcohol a day for men. And there are some gender differences with how alcohol is metabolized. So if that's something that's new information, just wanted to name that. And that's the reason why the guidelines are different according to gender. So, and then the risks increase if alcohol is used in the context of medications that interact with alcohol. And many times people just may not be aware that alcohol is even interacting with the medication. Or they may only think of that with prescribed medication and not think of it with over-the-counter medication or other supplements. There can also be increased risk if there are medical conditions that could worsen with alcohol, as well as in the context of driving or other activities that would pose similar risks. And so, a lot of this, of course, goes right back to alcohol being metabolized differently, and so people being more sensitive to the effects even when they drink less. And then the increased risks around confusion, falls, and injury, which then also worsen existing health issues as well. So a really, really simple, brief intervention potentially is even just offering some information or having information available around these drinking guidelines. And this is something that we could really be talking about in any setting if we're talking about it in a way that is culturally responsive and is respectful. So some increased risks associated with alcohol use. And let me mention now, actually, while it's on my mind, that one of the reasons that I'm focusing so much on alcohol use is because alcohol is the most commonly used substance in general, really at any age, but especially for older adults. And so that's why there's a lot more data on alcohol use in older adults, as well as a lot more attention on alcohol use. But that said, a lot of what I'm sharing today can also be applied to other substances, especially once we get to the evidence-based practices and screening and assessment and all of those pieces. And that can absolutely be applied to other substances as well. So some of the increased risks associated with alcohol beyond the guidelines. And this is something that can be important to offer folks so that it's clear that these guidelines weren't just plucked out of thin air, that it's not just that people are saying you shouldn't drink so much, right? But that they're based on data related to medical risk. So first, the health stressors. So exacerbation of existing health conditions. And that these health conditions, is a lot of different health conditions, more than we could certainly list on just one slide or one handout, but some of the most common ones as well that people tend to experience, including high blood pressure, diabetes, cancer, and depression. There's also negative impacts on sleep, which we know that our sleep quality tends to change as we age, as well as the interaction with cognitive changes like we discussed before, from mild cognitive impairment to dementia. And that all of this, of course, is associated with an increased risk of loss of independence, which we know is highly, highly valued by many, many people. Now, depending on your setting, you will likely want to, when you offer this kind of information, you will want to tailor it to your setting and to your community. So if there are, for example, very high rates of high blood pressure and diabetes in the community where you work, then you would want to be sure to have some specific information on that. And even include information on interactions with the most common medications used to manage both of these conditions. Or, for example, if you are in a health setting that specifically focuses on cognitive health, right, and supporting people who are experiencing cognitive changes, then you would want to have some information that's specific to cognitive changes. And also, of course, always make sure that any information that you're offering is accessible so that it speaks to people's cognitive strengths, that it's accessible in that way, and then also linguistically accessible, so having things available in multiple languages, and then, of course, culturally accessible. And then increased risks, aside from health stressors, a lot of the ones that we've already talked about, but what you'll see here is that it actually, we're on the other end of kind of that direction now. So before, we talked about how a lot of these different life stressors increase the risk of developing some kind of concern related to alcohol or other substance use. Now we're talking about how increased alcohol use beyond the established guidelines can actually act as a risk factor for these very life stressors. So it actually can be somewhat of a cycle here where the risk factors feed into each other and kind of become a very complex situation that then kind of becomes a spiral there. And so this can also be helpful information to offer in the context of talking about alcohol use within established guidelines, um, as people, just so people have the information and we can support informed decision making. So we are never offering information to try to, scare people, or, we know that scare tactics don't, tend to shut down conversation. Um, it's not meant to try to lecture people on potential consequences or anything like that. It's really, the spirit here is to offer information in order to have collaborative discussions and to be able to support their informed decision making, as well as hopefully be able to prevent or at least mitigate some of these potential harms. And then some of this is the last piece that I will share here in terms of the background and context and unique risks, is that there are some very unique risks in the barriers to screening for older adults, screening for alcohol or other substance use that may pose a risk. So that's screening. So first, you know, so I'll say this. So these risks are in addition to a lot of very common barriers that people face across the lifespan, across communities. Barriers such as lack of transportation, lack of financial resources or insurance, right? The social isolation, things like that. So in addition to those, then the risks and the barriers of ageist beliefs that older adults just aren't at risk or that wouldn't be interested in or benefit from services. There's also a risk around, a lot of the different life changes and health changes that people may be experiencing. There may be a lot of effects that are similar to some of the effects of risky use of alcohol or substances. And then, some of the signs of that kind of alcohol risk kind of gets missed in the overall aging and health, right? Or there may be so much going on in the different transitions that then the alcohol and the substance use just totally gets missed as people are attempting to be a support around these other life transitions. And then also, as we talked about before, providers and social supports hesitating to notice, and sometimes that is subconscious. Sometimes we are kind of overlooking it and we don't even realize we're overlooking it. And that's where implicit bias comes up, and it's really important to make our implicit bias, bring it to the forefront so that we are aware of it and can manage it, and we aren't making decisions based on, bias that we aren't even aware of. Or we might just hesitate to discuss the substance use. And so in that way, I'm so happy that y'all are here today, because what we're going to do next is that we are going to talk about some best practices in screening and assessment. So I want to pause for a moment here and open the floor for questions. Are there any questions that have come up on what we've covered so far? All right, I'm not seeing any questions. We are almost halfway through our time, so let's go ahead and take our midway break. And then, oh, I just saw a question come in. Okay, hold on. Don't leave yet. We're not going to go to break yet. We're still running ahead of schedule. So the question is there an age statistically when these stressors, particularly around health, begin to present? So a lot of times, thank you so much for that question. A lot of times, people, generally start talking about these stressors around, anywhere from, well, I'll say this. A lot of times people are talking about 65 and older, but depending on a person's situation, their health, their environment, right? A lot of these stressors can start earlier. So people may start experiencing this, earlier in their 60s, and then depending on their life circumstances, even earlier potentially. So if people have had a lot of, a lot of trauma, people have experienced a lot of trauma or, hardship, physical health conditions throughout their life earlier, then we can certainly see that the risk for some of these other stressors start coming up much earlier in their experience. So a best practice is really to think about, you know, uh, what are the health stressors that may be coming up for folks 55 and older, not waiting to 65 and older, because the more that we can be aware of some of these different stressors or risks that people have, the earlier that we are aware of it, the more that we can do in terms of mitigating and preventing and helping people be as healthy as possible. We certainly don't want to wait until things are, at a health crisis point to start screening and intervening. Absolutely. Thanks so much for that question. So we will go ahead and take our break. Rebecca, could you remind me, is that a 5-minute break?
Yes, it is a 5-minute break. So everyone, we will meet back at 10:56.
Thanks so much, everyone. Let's do 10:57 because I saw the time just changed.
Sounds good.
Okay, see y'all then. All right, welcome back, folks. Hope you had a good break. Okay, so now that we have a lay of the land, we'll be talking about screening and assessment. And first, I want to hear from y'all. What do you see as some best practices when it comes to screening and assessment, regardless of age? What do you see as some best practices when it comes to screening and assessment, regardless of age? And here we have our first person who says, listen. Yes, listen. Oh, how often do we feel like someone asks us a question and doesn't actually listen to our response, right? So listen. Use evidence-based tools. Don't make assumptions. Keep judginess voice out of your tone. Love it. Treat everyone with dignity and respect. Yes. Ask the question. Don't walk around it. Yeah, there are times where we might use like euphemism to kind of talk around a question, and they are so unclear. People don't even know what we're asking them, and it's so hard for people to, to answer it if they don't even know what the question is that we're asking. Absolutely. Using short screenings, particularly in primary care doctor's offices. Yes. And someone here says the audit and cage questioning tools. Yeah, we'll be talking a little more about those. Active listening. Use different therapeutic interventions. Yes, there's a lot that we use in just our overall counseling approach that's really important in the process of screening and assessment. Consistently follow set in place policy and procedures, right? That if there are best practices established, then use those with fidelity. Restate to ensure the message is clear. Absolutely. There are times where we need to restate a question. Unconditional positive regard for the individual. Yes, that people have that felt sense that we are truly there to understand, to come alongside, to be a support in whatever way they would find supportive, and that there's really nothing that they could say that would cause us to judge them, that would cause us to, disengage from them. Absolutely, that unconditional positive regard. Don't lead the question. And this is such a great example, right? So don't ask a question with, you don't do this, right? Or this isn't a problem for you, right? Yeah. And then here, another way to approach screening and assessment, the 4 Ps, asking about parents, past, partner, pregnancy. And then here, yes, the someone is saying, I'm not seeing any comments in the chat box. And so the way that this platform is set up is that you won't see other people's comments, but I will read each one of them out loud. So you'll still get a chance to hear each of them. And then use positive I messages. Great. Thanks so much, everyone. And feel free, as you have more thoughts, feel free to keep it coming. So the next thing we're going to do is actually watch a short video, a short demonstration video. Rebecca, could you help me get this to play?
Yes, I actually have to play it, so it's going to take me just a second to get set up and it will start playing.
Perfect, thank you. All right. Um, so I see folks have already started putting in the chat some of their reactions. So please, please put in the chat and I'll read out loud. What was missing in this demonstration? And what would you try differently? So I see here in the chat, she's not listening to him at all. She's only talking over him. Shake my head. That was horrible. She is so insensitive. What would you try differently? Empathetic approach. Need more active listening. It was missing empathy, missing compassion. And then someone says, I think this is the reaction response most people would have to her. She was not listening. And what she needs to do is to show up in a way that isn't raising his defenses, right? People's defenses get raised because they feel attacked. What she could do differently. Well, from the very beginning, she could introduce herself and actually listen to the person. Also asking what he feels like he may need. It really came across like all she was concerned about is checking off the boxes and treating him like a number. Absolutely. And he picked up on that and he didn't like it, right? Nobody likes it. Also here, she's ill prepared. She's not explaining anything. She's not even introducing herself. And she's already determined what the result will be. Yes. She already has an idea in her mind of what the result of the screening is going to be, what this gentleman will need to do next, right? She's already decided. Really lacking that openness. All right. So now we're going to watch another video. Oh, wait. Okay, here comes another one. Sounded like the check the box was a pretty standard clinical intake and subsequent pretty standard response. We can get hardened. Yes, yes, absolutely. You know, when we watch a demonstration like this, it can feel easy to see what the person's doing wrong and talk about what they need to do differently. And also noticing at the same time that, you know, any of us on the wrong day with the wrong kinds of supports in our workplace, right? We can all have a bad day and end up doing some of these things without realizing it. And so noticing, right, where we're at and what we need to have in place so that we don't show up in this way, right? Oh, and here someone says, I would have walked out on her. Yeah, it felt really activating. It felt really disrespectful. I'm like, why am I even here? Right? And we even heard him say that. Like, what is this about? And what to do differently. Be kind and respectful, interpersonal, and show that you are just concerned with no judgment, right? Yeah. All right. So that now we're going to see a different demonstration. A demonstration, yes, that is also, I'll just say that, a different one. And what I'll say is that this video is, I want to say it's like 18 minutes long. We're just going to watch the first 6 minutes. And so I'll also provide you with the links so that if you want to watch the full video is not just a screening, it also has you know, brief intervention, and it has a lot more pieces to it. But we're just going to watch that beginning kind of screening part to mirror what we just saw now. Thanks so much, Rebecca. You can go ahead and play it. All right. So now inviting folks to put in the chat, what did the counselor do differently? And how did that impact the person's response? We see here in the chat, much better. Listened and connected with him. He was much more engaging. Yes. Much more professional. Yes. Engaged, more thorough. Absolutely. You could tell that the provider was much more prepared, much more engaging, and the person responded with greater openness, trust, being more engaged, and they were able to actually have a real conversation, right? Much more respectful and kind, showed empathy and compassion. The counselor asked some open-ended questions, made eye contact, and built rapport. Here we see he probably felt much more involved in the process, that's for sure. Active listening, less judgmental. Yeah, and you can tell with the rapport, right, that she was able to engage him more. Like there was a point where she asked how much coffee he drinks, and he said 6 cups, and she said, ooh, right? And if they didn't have rapport, that might have come off as judgmental. But because they had established some of that rapport, he kind of laughed and was like, yeah, I'm a coffee hound, right? And it actually helped develop more of their connection during that screening. The person was more engaged, the person was smiling, they were willing to share, right? Makes sense. And he treated her like a professional due to her being prepared. Yes. The counselor personalized it to be about the person, the patient, not about the test, right? It wasn't about, okay, you have to sit here and I'm going to, fill out this form and score it. It wasn't about treating the person like a number. The person didn't feel treated like a number. And a big part of that was how she was able to contextualize all the different pieces in the person's overall care. She conducted herself professionally, but also showed some humor and human connection. And the man was clearly more receptive and comfortable working with her because he wasn't being judged. Yes. And then here we have liked her explanation of why he was referred to her. Yes, she took the time to contextualize their interaction together, to explain what it was about, and then also find out from him, what was his sense of what this was about, right? And when he said, like, I don't really know, right? Then a perfect opportunity to clarify that, have transparency, and orient to that interaction. And that all is so important for helping a person to feel respected and comfortable and engaged. And she started by asking him so that if he did have a sense, if he was to say, you know what, the doctor said I should talk with you before, prescribing other medications, right? Like, then that's something that she could go back to and really kind of integrate throughout their interaction and be able to connect those dots. And then lastly, here I see she was talking to him, not at him. Absolutely. Huge difference. Huge, huge difference. And just like we see the difference, people feel the difference, right? So in the slides, which have been a link to the slides have been put in the chat, and all the links are active, should be active in the PDF. So these are all videos that are available to watch for free on the internet. And there's screening and assessment, building motivation for change, brief intervention and continuing recovery plan. and then working with family. So our overall approach in screening and assessment, our interview style needs to be respectful, relational, non-judgmental. We need to protect confidentiality. So this includes having informed consent, of course, and that the person trusts privacy protections, right? So that we're explaining it in a way that engenders confidence and that they have a sense of how their information will be used, who has access to it, right? So we saw in that in the second video that she was very clear in the beginning, that because she's part of the same office with the physician will have access to what they discussed today, right? The purpose of the questions are clear and relevant to the person's context and their self-defined goals. And we, of course, can only know that if we ask about their self-defined goals and their context. That questions are clear, direct, and strive for objectivity so that we're not using terms like, do you drink too much? Well, what's too much, right? So that we're striving for objective questions that we aren't relying on people to have to interpret when they respond. And that there's an orientation to the screening that will help the person have a sense of what will be the structure of the screening, what will be some of the content of the questions, and ultimately, what's the purpose of the screening. None of us like to answer questions if we don't even know why we're answering them. And then we end up more focused on why is this person asking me this, and what is this going to lead to, and how is this information going to be used? What does this have to do with me? Versus focused on the actual interaction and questions at hand. Now, these are some overall general tips to improve screening, particularly with older adults. And I would say that this is also really important screening in general, right? Now, something I'll name here is that it's still important to be culturally responsive and attuned. And so very direct questions might not be culturally congruent for some people, and some people may really shut down in the interaction. So some things that can be important are to gather local knowledge and connect with community. So that when you are using these different kinds of evidence-based screenings, when you're developing your screening program, that you are, or the screening component of a program, that you're also tuned in to local culture and community, and that if very direct questions are going to feel really disrespectful or invasive, that then you are working with community stakeholders to find ways to make those more culturally accessible. So some more tips on screening. Make it routine. So some of the things that we can do is have an annual screening around alcohol and other substances for people ages 60 and older in other settings, right? So in healthcare settings and home healthcare settings, right? All those different settings that older adults may be more likely to access. In that screening, we also want to include screening for major life events, especially retirement, grief and loss, changes in health and housing, and other major life changes. We want to embed questions around alcohol and other substance use in overall questions regarding health behaviors. So it can include things like physical activity, nutrition. You noticed in the second video, she also talked about coffee intake, right? Obviously coffee is a substance, but many times, but you'll notice that as she was talking, it wasn't only about alcohol or only about substances. And that she also took the time to pause and just be human with him. That when he talked about his loss, she acknowledged that, right? She expressed regrets around that loss and checked in with him about how he's doing. Also checked in with him about his social supports and his children, right? So having it be more holistic in that way. And then, of course, there is a growing use of cannabis, both for personal use or medical use in places where medical use is approved. So don't forget to ask about cannabis, as well as non-prescription use of prescription medications. Here are some different evidence-based screening tools. The ones that have an asterisk next to them are ones that have been meaningfully tested with older adults. So that whenever we're using an evidence-based screening tool or any kind of tool, we always want to ask, who is it evidence-based for? Right? We don't want to make assumptions that it has been tested with the population that we serve. And so in that way, I've highlighted some of the ones here that have been tested with older adults. At the same time, we know that people have many different cultural and social identities. And so if you will want to take a deeper look to see how the research populations match up with the people that you serve in your setting, right? Were women included? What is the racial and ethnic composition of people included, right? Did they report sexual orientation or gender identity as part of the research? So keeping in mind that people are multidimensional and that age is only one dimension of our social identities. And then also wanted to share screening tools for co-occurring mental or cognitive health. As we know that many people, as they age, may have increased risks of developing different kinds of mental health or cognitive health concerns, then these are some different tools that may also be useful, depending on our setting and our population. You'll see here there's co-occurring conditions in general, depression, anxiety, PTSD, trauma symptoms, and elder abuse, and then cognitive impairment. Now, one thing that can be helpful to assess is whether the person has had an early onset of concerns relating to alcohol or other substance use or a late onset. One of the reasons that this can be helpful to assess is because it can inform what services may be a better fit for the person. That said, people always determine what services they are interested in and they want at that point. We're not here to prescribe or force that by any means, but this is some information that can help guide our assessment and that we may share to support informed decision making. So an early onset, this is where problems related to alcohol or other substance use began prior to age 50. There may be more intersecting needs because of this being a longer term concern, and it's also more common. It's more common that somebody who is experiencing some risks or concerns related to alcohol or other substance use in later life also had some of those concerns earlier in life. That doesn't mean that they never had periods of time where it wasn't a concern, but it's just more common, right? That some of the things we've been dealing with would then persist later in life or come up again. Now, late onset is that it began later in life. It may have begun because of an age-related stressor. So maybe somebody who maybe didn't ever kind of experience concerns related to alcohol use, and now that they are dealing with grief, now a concern has come up. Or if they had earlier concerns around alcohol or other substance use, they also had long periods of stability. So maybe somebody who may identify as being in long-term recovery, and then maybe with some of these big life changes or transitions, then has kind of a resurgence in that earlier concern. Now, something to note about late onset is that this can be really easy to miss without the appropriate screening. So here are the general next steps. So we have screening. The results of that screening might be none or mild, and then typically we would offer affirmation around that and really just support the person's health, so those health promotion activities. Or the results of the screening may be more moderate or significant concerns, and then there are a range of options around informal supports or formal supports. It's incredibly important to honor personal choice and many pathways. So while some people may want or need a formal substance use disorder treatment service, a lot of older adults accomplish their desired changes to their substance use through informal approaches. So we want to honor personal choice and many pathways. And when in doubt, we want to start with the least intensive approach and then build from there. So we do not want to have a screening, just to be super clear, we do not want to have a screening where a moderate or significant kind of risk of concern is found and we just hand someone a referral to treatment. That is not what is going to be a best practice when working with older adults. We want to really discuss the range of options and support informed decision making. And when in doubt, start with the least intensive support and then build from there. So what's included in informal and formal support? So in the informal and less intensive side, this includes things like discussion with the providers and social supports. So let's say you are a behavioral health consultant working in a primary care setting, or a nurse working in a primary care setting, or a therapist working in a memory care setting, right? This might include informal discussions that include the person, other providers on the team potentially, and then any social supports that they name and want to include. Can also include offering information or psychoeducation, and then brief interventions. So for example, screening, brief intervention, and referral to treatment if needed, if wanted, that's a brief intervention. And the brief intervention there many times is things like, strategizing together to, the person may set a goal around decreasing their alcohol use to come within those established recommended guidelines. And then you would support them in being able to make a really, really concrete and tangible plan around decreasing that alcohol use, a way to monitor their alcohol use so that they know how much they're drinking, they can track it, and then having a built-in follow-up, for example. And we'll talk more about what brief interventions can look like when they're evidence-based for older adults. It can also be brief interventions that are either individual or group interventions. So a brief intervention here, it might be like a brief therapy. It could be anywhere from 1 to 4 sessions of individual support with some follow-ups. So those are some examples there on the informal or less intensive side. And then on the formal side, which is typically going to speak to specialized substance use disorder treatment services, there are brief therapies. Those then start to go anywhere from 4 to 12 sessions, and those could be individual or group. And there's a lot of different brief therapies that are evidence-based. Then formal specialized treatment, ideally a treatment that would offer age-specific and age-appropriate care, and then continuing recovery programs as well. That can be included there. So now getting to principles and evidence-based support. And if there are questions coming up along the way, please, please, please include them because we will save time at the end for questions. And so that way we can go right into questions. So what's been found time and time again is that the importance of countering ageism and negative stereotypes. And that what studies have found time and time again is that older adults are generally open to this kind of support, are accepting of this kind of support, and especially when programs offer age-specific groups and age-sensitive treatments. So treatments that meet their unique needs and realities, and that providers are trained in issues that are unique to older adults. So studies have found that older adults who participate in alcohol treatment are successful in reaching their treatment goals of abstinence or risk reduction and have nearly the same or better outcomes than adults who are younger than them. And they're more likely to complete treatment than adults who are younger than them. And all of that really hinges on access to age responsive and appropriate treatment. And that older adults uniquely benefit from age-specific treatment. So what do we mean when we say age-responsive services for older adults? So regardless of the setting, regardless of the kinds of services that may be offered, their older adults are much more likely to benefit and have benefit from the service effectiveness when the service is supportive and respectful, forms that partnership, when services are flexible, and this includes honoring accessibility needs, meeting people where they are both physically in the community, and offering phone or tele-based services, and also meeting people where they are emotionally, where they are in their process. That services are sensitive to gender differences. So an example here is being aware of and responsive to the fact that women are more likely to be prescribed psychoactive medications than men. Women are more likely to be prescribed a medication that may interact with alcohol, right? Sensitive to cultural differences. So for example, ensuring linguistic accessibility and recognizing, celebrating, and building on cultural strengths. Oh, oops, went too far. Services that are sensitive to the person's level of physical and cognitive functioning. So really speaking to those physical and cognitive strengths. So that might include things like using shorter sessions or meeting in a room that is close to the building entrance and providing information in both verbal and written formats. And services that are holistic and thorough, that includes addressing cognitive, physical, social, mental, financial, emotional, and spiritual factors that may play a role in overall health, wellness, and well-being. So, treatment and services are, we can say, never effective when they're cookie cutter or one size fits all. And so what we say here is that that becomes even more true when it comes to services for older adults. And then finally, that services are focused on helping people develop and improve coping and social skills. And really here, it's not even social skills, it's social connectedness, instead of focusing on internal mental processes. So more skill-based and resource-based than necessarily trying to change an internal mental process. So these are things that can include using strategies that focus on behavioral changes that reduce risks related to substance use and increase quality of life, such as developing problem-solving strategies to manage cravings and strengthening social connections. And that in this, it's important for us to embrace culture and address bias. That bias increases the risk of homogenizing older adults, treating all older adults as if they're the same. That we need to recognize and celebrate the full diversity. We need to recognize cultural resources in wellness and address ways that bias contributes to widening health disparities, So, for example, there are higher rates of death, disability, and chronic illness amongst older adults who identify with diverse racial and ethnic groups. That's where the social determinants of health and the cumulative health burdens from the marginalization kind of come to a head. LGBTQ older adults may experience poor health care and lack of access to services because of discrimination and prejudice. They may feel like they have to hide, or they may either have to hide or feel like they need to hide their LGBTQ identity to receive care. And of course, anytime that someone feels like they have to hide a part of themselves in their services, that really makes it makes it so those services cannot be as effective and accessible. And then also recognizing gender-related disparities that then create and compound health disparities in older adults. So things like older women being at higher risk for co-occurring mental health concerns and social isolation compared to older men. And as I said before, being more likely to be prescribed medications, particularly benzodiazepines, that negatively interact with alcohol. So take a moment and think about the importance of culture and how it impacts experiences of both aging and substance use. And think about elders in your community. Or if you are an elder, think about yourself and your cultural identities. What would be important to consider when engaging elders in your community? Give folks some time to put something in the chat there. What would be important to consider when engaging elders in your cultural and social communities? Something I'll say for my own cultural and social community, being the child of immigrants, that some of those natural supports that would have existed, like extended family, in my parents' country of origin, um, they don't have access to or don't exist here as people who have migrated. And so the importance of building those social networks um, and forming kind of those chosen family. And here we see in the chat, making them feel useful, making them feel relevant. Noticing that gatherings of local gatherings of elder groups, there's a lot of alcohol as part of the events. So recognizing the availability of alcohol there and how it may be normalized and how it may be really hard for somebody who's trying to have a different relationship with alcohol. Cultural communities, linguistic barriers, family supports, normalizing the involvement of children in care, religious beliefs and religious organizations. Make them feel needed. Most want to work but feel that they're too old, feel like maybe they've been pushed out of the workplace. What might be the person's spiritual religious connections? The church community may be a benefit. Yes, and here someone says, I do live in a 55 and over community and have a presentation plan in 3 weeks in regard to suicide in the older age group and internet scams and internet dating. Many in the community are disconnected and embarrassed if they have an alcohol problem. So bringing them together and letting them know they're not alone. The social community, the local support groups, the volunteer groups are opportunities. And here we have, I just believe that a human being is a human being. Elderly people are aware that they're aging, but their spirits don't change, if you will. And any elderly person could go into extreme stress and pain when they suddenly feel like they're being treated differently. The human being is still the human being. Yes. So often, a way that ageism manifests is this kind of infantilizing of adults or thinking that they're somehow different, right? The homogenizing of elders, that all elders are the same and they're just this way, right? And understanding that 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 is not the case and that we're people, right? And that all people deserve to have that basic attention to themselves as an individual, as a family member, as a community member, and as a person with their own unique strengths and preferences and desires and goals and capacities. Absolutely. Knowing the needs of the community and how to provide the needs, considering their specific needs. Yes. Yes. But they're more experienced, wiser, and awesomer. I hope to become more experienced, wiser, and awesomer as I age. That's a life goal for me. Yes. Just someone to listen to when they talk, someone to listen when they talk. Yes, not being dismissed. Yes. Mm-hmm. Thanks so much, folks. I see there's more here in the chat. Unfortunately, because of time, I need to keep going forward, but thanks so much. So for engagement and retention, some things that are particularly important here are collaborative relationships, so people don't feel talked at or told, right? A culture of respect, offer proven services. And proven services often refers to evidence-based practices, which we'll summarize later. But remember that this might differ for some people, that for some people, their own cultural resources and practices are really what is most desired and most rich and most effective for them. So for some, proven may also include cultural practices that have been handed down through generations, and that's how they're proven, and not necessarily only through research-based methods. Accessibility matters, and then having special considerations in groups. So groups that are age-specific versus mixed. Now, if your program only has mixed age groups, some things that can help here are emphasizing privacy and confidentiality, being sure that any physical needs are accommodated, being really clear around establishing group norms for respect, and ensuring that older adults' voices are heard by creating those opportunities to share without creating pressure to disclose. That people may have really different ideas about what they feel comfortable disclosing in a mixed age group setting. That groups also are offered specifically for people who have experienced trauma or that are gender specific, and that there are groups offered for people who are experiencing co-occurring pain. Those are some pieces that we can think about in offering specialized groups. Embracing health risk reduction practices, that a lot of older adults may not be interested in abstinence-based goals and goals that say that they need to stop completely and never use again. And that this is a really important place to honor personal choice, and that risk reduction works, that it has been found that risk reduction can bolster overall functioning, can reduce physical health risks, and is associated with improved mental health. And that if we try to force our own solutions, it's just really going to lead to disengagement. And that goes hand in hand with person-centered care. So that person-centered care collaboratively centers the person's self-defined goals, preferences, values, perspectives, and their desired social supports as they name them. And that we have attention to engaging and expanding social supports. That when social supports are engaged and expanded, that is associated with improvements in overall engagement and retention, as well as improved outcomes and just social connectedness, which overall needs to be its own outcome. That's how important it is. And here I see in the chat, yeah, idle time is difficult for anyone who's dealing with any kind of concern related to alcohol or other substance use. And so when elders are retired, community services, friends, and support is an absolute necessity. Yes, thanks for putting that in the chat. So what are some evidence-based, evidence-supported practices with older adults? So as I go through this list, please, please, please share in the chat what are some that you're already using and could do maybe a little bit of work to, some tweaking here and there to make them even more responsive for older adults. So brief interventions, motivational interviewing, cognitive behavioral therapy, skill-based approaches, problem-solving therapy, 12-step facilitation, medication-assisted recovery, individual counseling, groups that are age-specific, and couples or family therapy and family involvement in general. Integrated approaches, meaning that concerns related to alcohol and substance use are integrated into other forms of healthcare or other settings. So more holistic approaches, we could think of that being co-occurring care for co-occurring mental health or cognitive health, and then of course linkages and care coordination, especially when we have take into account that people can be managing a lot of different specialists or a lot of different service providers. And I see here really common CBT, motivational interviewing, care coordination, right? The things on this list aren't necessarily brand new for us. It's more so thinking about, are we doing them in a way that are really responsive and age sensitive? So the last thing I'll do is I'll just walk us through what are the brief intervention parts that are specific for older adults. And so if you have any questions, now's the time to start putting it in the chat so that when we have that minute left for 1 or 2 questions, that we'll be sure those questions are there and we have time for them. So first, asking the person about future goals. This can include health, activities, hobbies, relationships, financial stability, independence, right? And it's really important to start here. Otherwise, we have no context. We have nothing to contextualize within. Second, adapt your feedback based on the person's responses to screening questions related to drinking patterns and other health habits. Third, in the case of alcohol, discuss how their use of alcohol compares to others in their age group and offer information on standard drinks and those established drinking guidelines. 4, you can discuss some of the pros and cons of substance or alcohol use if appropriate. So this can help us to understand the role of substances in that older person's life, including its role in coping with loss and loneliness, and that we're doing the pros and cons not to try to persuade them to change. We're doing it just to get a lay of the land, right? What's going on? What's coming up for the person? Offer some information on the effects of heavier drinking or other substance use in a way that is non-judgmental, right? 6, discuss the person's reasons to cut down or quit. Things that are really common are like staying independent, having good health, things like that. 7, offer information about drinking limits and way to cut down or quit. We don't want to assume a person's goal, right? So this needs to be really tailored for the person. And here are some different ideas. 8, create some kind of mutual agreement around what their goal is for drinking or other substance use. And it can be helpful to have like a very, very simple plan that is signed by both people. It makes it a little more tangible. 9, discuss ways to cope with risky situations. And then finally, summarize the session. So with that, I'll be sure to share references and resources, which are also in the slides. I want to say thank you so, so much. Please, please, please feel free to connect with me. And I have 1 minute left. I don't see any questions right now, so I'm going to hand it back to Rebecca to close us out. Thanks so much, everyone.
Thank you so much, Gabriela, for the wonderful presentation. As usual, you're getting very high marks in the comments. Everybody thoroughly enjoyed it. It was a really good presentation. So thank you so much. And as you can see, we have included Gabriela's contact information so that you may contact her with any further questions that you may have. And everyone, please make sure you stay on for a couple quick items of business before we conclude. Please see the chat panel for a link to today's survey. Additionally, when I conclude today's webinar, your browser will take you to an evaluation on FADA's website. If you want to receive CE credits or statement of credit for this event, you must complete the evaluation. You'll be prompted to register or sign in to complete the evaluation, and you can register as a visitor at no cost. For CEs to be reported to CE broker for Florida licensed healthcare practitioners, you must provide an accurate Florida Department of Health license prefix and number. After you register or sign in, you'll be directed onward to the evaluation. You must use the same email address you used when you registered for our webinar as you do when you set up your profile in FADA system, as this is our only way to connect your attendance and your profile. You will get a second opportunity to complete the evaluation through a follow-up email later today. The sender will be messenger@webex.com. Please note that the evaluation will close Tuesday, April 19th. We do not email statements of credit. Instead, after we verify attendance and completion of the evaluation, a statement of credit will be generated as a journal entry within your profile 30 business days after the evaluation closes. If you do not know how to access your journal entry, please visit our frequently asked page on our website, and that will direct you exactly how to access your journal entries. Thank you all again for participating in today's webinar. We'd also like to especially thank the Florida Department of Children and Families, Office of Substance Abuse and Mental Health for funding today's education. Thank you, everyone, and have a great rest of your day.